Thank you, Miguel, for the presentation, the kind invitation to give this talk and to discuss with you what are the biomarkers in the field of transplantation and what we can make with these markers. This is my group. We work in Turin. Turin is a quite big city for transplantation in adults, and of course we also have pediatric transplant centers, although we are quite a small area. So this is my team. As I was saying, I'm a pediatric nephrologist in Turin, Italy, and I'm coordinator for Turin of the TransplantChild group. I'm also a member of ERNT and European Society of Pediatric Nephrology and certain working group. I'm working with many of you in collaborative studies. These are my disclosures. And so we'll move to our journey today in the complex world of biomarkers for kidney transplantation, trying to give a pediatric perspective, which is not that easy. Actually, a biomarker is something that we'll see what meanings can have, and starts from exploratory studies, then has a long journey until becoming approved and validated through randomized controlled trials. Biomarkers we are used to, we just will mention some of them, are rapidly moving to the future with new indications and taking advantages also on the new omics techniques, either on urines and in blood. And we'll go through these different opportunities. Let's go back to see for a moment to what is allorecognition. Allorecognition is a complex event, very complex, and we are exploring and getting to know new pathways day by day, starting from the donor. Then something is happening in the graft and during the graft transportation over conservation period. Then there's also ischemia reperfusion injury, and then the allorecognition, which is a quite complex event involving all the cell types circulating in blood, the endothelial cells, and taking advantage also of different types of mediators that we can get to know day by day. So more cytokines have been identified being involved in allorecognitions. Many mechanisms considering the extracellular vesicles, cell-to-cell interactions, and the involvement of other cascades of events, so that allorecognition is really a complex event, which is difficult that we can reduce, to think that we can reduce to just one or two parameters, which are most of the time those we are using to evaluate the quality of the graft and what's happening in that graft. So how can we reduce such a complex event in some markers? Many actors are playing simultaneously, not only T cells and B cells, but we now know that NK cells have an important role, and also monocytes and the neutrophils have been added recently to this series of cells, to soluble mediators, cytokines, antibodies, and complements are involving other cell types and amplifying the phenomenon. Then we know that the microvascular inflammation can occur in what we described as glomerulitis. The tubular cells are also involved, retrieving also inflammatory cells to the interstitium and giving tubulitis. So all these complex events are really difficult to reduce to one single marker, which most of the time we are using every day. But to define what really is a biomarker, I think we have to just make a little step behind and go back to the basic definition of a biomarker. Biomarker, if you want to accept a basic definition, is defined as a characteristic objectively measured and evaluated as an indicator of normal pathogenic biological processes or responses to an exposure or an intervention. And every medical how can I say, parameter on molecular, histologic, radiographic, or physiological characteristics can assume the capacity to become actually a biomarker of a phenomenon. The main characteristic of a biomarker are the capability to identify patients with high disease probability. So a biomarker is some parameter which can help us to identify with a high probability, avoiding false over or under rating of the phenomenon in different independent cohorts. So the biomarker must be accurate in expressing the phenomenon. And usually we are used to evaluate and express the quality of the biomarker with some what we call metrics. And what are these metrics data? Metrics data express the sensitivity, the specificity, the area under the operating characteristic curve, so the AUC. And then we usually consider the predictive value, which is the capacity to predict a clinically relevant event. Usually we talk about the negative predictive value, meaning that this biomarker allows to exclude confidently the disease, for instance, and the positive predictive value, which is the value to confirm the disease status. So with these metrics, if we go to the field of transplantation, for instance, we can consider what the graft biopsy can give us. So in the field, the most simple, we can consider the graft biopsy as an indicator of acute rejection. And here we can consider in this field the sensitivity, or so the ability to identify the true positive, so the presence of the rejection, the specificity, which means the ability of a screening test, in this case the graft biopsy, to detect a true negative. So when it's negative, it should be really negative. And the positive predictive value substantially means that it's the proportion of those who tested positive who actually have the disease of the condition. So what we think can be an expression of the rejection should really express the rejection, while those cases which we think are negative should really demonstrate to be really negative. These are usually tabled in this type of table, which basically expresses specificity, the true negative, sensitivity, the true positive, the positive predictive value, the ability to identify the true positive and give a positive outcome, and the negative predictive value means that who is negative should really prove negative afterwards. This is just to remind you, because all the tables you'll read in this along this presentation and also in papers usually refer to these metrics. But see, let's go now to see what is the biomarker journey. So the biomarker, some parameter before it can be considered a biomarker should undergo a long journey, because for instance, most of in the field of allograft biopsy or rejection, we started to considering the gold standard, the biopsy. But, however, the biopsy is invasive, is prone to errors, can be non-informative because detecting alterations which are not expression of the rejection, and sometimes the prognosis value can be variable. While we think of an ideal biomarker of something that can be rapidly obtained, which is cost-effective, which is minimally invasive, can be acquired routinely, have a high accuracy according to the metrics we saw, and to predict the future of this graft. So maybe we can compare with the what we consider the gold standard, other parameters selected in different biofluids. So we can choose urines or blood and obtain non-invasively information from these biofluids, to which we can add also extracellular medium and exosomes as new biomarkers, and we will go through this. For instance, this is the case of, for instance, of proteomics, which are methods we will go through, where we can find in an initial population for a different of a defined dimension, try to avoid the confounding produce a model and see if we can, these parameters, this signature, and we will see which proteins, and some proteins that can be put together and define a signature, can express what we can also see on the biopsy and give substantially the same information. Then this biomarker should be validated in another population, completely independent, and should be generally evaluated in multicentric studies and replicated with giving the same metrics and the same results. This, of course, explains how long might be the journey that a biomarker can need to become a biomarker we can rely on with confidence. The traditional biomarkers in transplantation we all know and we all use every day are mostly creatinine and proteinuria. Creatinine is certainly the most commonly employed measurement to determine the kidney function. It's widely available, it's very cheap, everybody can do it. It can repeat it, it's not complex, and every center in the world can perform it. However, it's not specific, it's not sensitive. And we know that it's a late indicator of subclinical rejection, and particularly in children who receive often large grafts, and where we perform routine biopsy or serial biopsy, sometimes we see that rejection can occur also in situations where no modification in serum creatinine occurs. The other old biomarker, non-invasive, which we use every day, is certainly proteinuria, which is quite easy to perform. However, the performance as a biomarker is quite low. If we consider rejections, this is not specific, and the high sensitivity is somehow conserved for adults, but not so specific for children. So many centers moved, following also what's happening in adult centers, to perform a surveillance protocol biopsy, which is certainly the gold standard for assessing the health of the kidney. So this means that every certain period a biopsy is performed. This gives an unbiased longitudinal approach, so we can compare previous histologic data. We can visualize the infiltrate and the damage. However, we can sometimes get mainly cellular-mediated cellular rejection signs and report this initial rejection and maybe treat the rejection preemptively before the rejection gives worse signs. However, the limits are many. The invasiveness, particularly in small children, which will require anesthesia. The risks are not negligible, since bleeding and arteriovenous fistula for repeated protocol biopsies is not rare. It's time-consuming, is costly, and is subject also to pathology interpretation. And moreover, surveillance biopsies generally are limited to the first 1 or 2 years after transplantation. It's quite difficult in every center to continue to perform biopsies after this period. And we all know that rejection is not limited only to the first 2 years. And finally, there's a problem of incidental findings. Sometimes there are no specific signs of chronic allograft rejection without real actionable inflammation or incidental findings which are difficult to interpret and to address. Another non-invasive biomarker is drug level monitoring. This is generally accepted as a biomarker of proper immunosuppressive drug use, which is quite diffuse, is routinely performed for some drugs, such as cyclosporin, everolimus, and sirolimus. And in some centers, it is usually performed also tacrolimus intrapatient variability, which correlates with the assay development in many assets. However, this in children is not so confidently accepted and is still debated differently from adults. However, drug level monitoring, for instance, for mycophenolic acid is not that easy, since a single sample trough concentration is not a good surrogate for overall exposure of the drug. mycophenolic acid area under the curve is not that easy to perform, since at least 2 or 3 concentration samplings for the drug are necessary, and 3 or 4 sampling for mycophenolic acid assays. So that requires that the children stays for the whole morning in the hospital. Moreover, steroid effective dose determination is still lacking. So even drug level monitoring is not that perfect biomarker we would like to have. In the last years, another biomarker has been added to our collection, which is donor-specific antibodies. These are antibodies developed by the transplant recipient against specific HLA antigens present on the donor kidney. And we all know that de novo DSA, so antibodies which were not present before the transplant and are developed after the transplant, are linked to poor graft outcomes, since they can mediate rejection, where in acute rejection, when they rapidly increase at high titer, or generated in sensitized patients, or are de novo responses maybe due to non-compliance in non-sensitized patients, but chronically they can damage the day by day the graft through different mechanisms. Certainly the most important is through complement activations, but also through antibody-dependent cellular cytotoxicity through the Fc receptor of NK cells, and finally also giving an endothelial chronic damage, activating endothelial cells directly through binding to the endothelial cells, which once activated may expose HLA antigens at higher concentration. Moreover, with donor-specific antibodies, we have the problems on how to interpret the MFI, which is the mean fluorescence intensity, which is not exactly the same concept as titer concentration. So we can have high MFI, so high mean fluorescence intensity antibodies at low titer, or high titer of mean fluorescence intensity quite low. So this, in any situation, these two concepts should be dissected and discussed case by case. Moreover, other antibodies can be detected, non-donor specific anti-HLA antibodies, which means that other antibodies against other HLA antigens different than the donor can appear, or non-HLA antibodies, which are antibodies whose role in rejection is still debated, although quite accepted to some of them, which are addressed against other molecules different from HLA, mainly endothelin 1 type I receptor, perlecan, agrin, vimentin, and mostly what is been studied in children, angiotensin 2 type 1 receptor. These antibodies altogether can have an additive effect with other antibodies, since most of the time they appear together with other antibodies. Just to overcome all these problems, particularly in the adult world, innovative diagnostics on tissue biopsy are being developed. These are known as tissue transcriptomics, and they rely upon the analysis of mRNA transcripts on biopsy tissue fragments on a microarray technology. This, of course, is invasive since it's on tissue biopsy, but it's very accurate and is known as a molecular microscope. The best or the mostly known is the MMDX, known as molecular microscope, where the fragment of the biopsy is processed and then different assets are read. The most used sets of mRNA transcripts for T-cell mediated rejection and antibody mediated rejection are the panels, mostly of interferon gamma inducible genes as CD80, CD86, and ankyrin R22. Other are selected for expressing antibody-mediated rejection, but also chemokines and other markers approved specific or advanced phases of antibody-mediated rejection. The other platform, which is quite used since it's commercially available, is the NanoString BHOT, which was set up by the Banff Wonking Group in 2019. This platform is commercially available and includes over 700 genes pertinent to rejection, inflammation, innate and adaptive immune response, and is categorized on annotation for different pathways. So we have the pathway for tissue damage, the pathway organ rejection, and tissue inflammation. These are the mostly evaluated pathways. Of course, our hopes are to move to non-invasive novel biomarkers, basing on the technologies and what the new technologies make available today. These technologies are called high-throughput omics technologies. And we have to consider that we can have two possibilities of use these technologies in a sort of targeted approach, where we have to look for candidate genes that we know from previous studies or from the literature that may be important in that process, or we can choose a non-targeted approach. The non-targeted approach is an approach starting from the opposites, where we look for everything without pre-selection, without any bias, and no candidate genes or candidate proteins or candidate mRNA or metabolic mediators are necessary, and we go and see everything, and we then make selections taking advantage of mainly of artificial intelligence or other supports that can allow us to put some filters and try to retrieve panels of information useful to describe our event. If we consider, for instance, on urine, what we can do on urine. Urine certainly has the advantage of being, particularly in children, quite easily available, is not invasive, and is the ideal matrix theoretically, because it represents the direct ultrafiltrate. And so in urine, we expect to find mediators of what actually is happening within the kidney. So multiple omics with taking advantage of these high throughput assays have been put up on using mRNA transcripts, urinary metabolites, protein panels, and genomes with different techniques. And we will rapidly go through this, which is a quite complex world, certainly developing quite rapidly and starting to give also some good information. Another field which we can add to these techniques is the one of extracellular vesicle. Extracellular vesicles are vesicles released from any cell type in the form of exosomes or microvesicles according to the size of these cellular parts which are releasing to mediate the communication between cells, and also allorecognition basis on the messages being transferred from one cell to the other through microvesicles and exosomes. These vesicles can bear on the surface proteins, receptor ligands, and membrane proteins, but also DNA and mRNA in the inside and lipid mediators, and can be analyzed since they are usually released freely in the urine, and can be analyzed, characterized with quite complex techniques. So they can analyze as being the cargo of information of what's happening actually in the graft. For these techniques, basically, mRNA multigene signature is the one that they gave so far the most important results. So some signatures for different RNAs were identified and expressed in kidney, where rejection was actually demonstrated also on biopsy. And multigene signatures were identified and able to distinguish T-cell mediated rejection from antibody-mediated rejections. However, although very informative, extracellular vesicles suffer from lack of a standardized procedure in isolation, purification, characterization, The experimental protocols for isolation and identification are very different and not standardized, and no study so far have included children, or at least the studies published. What has been done in an easiest, probably is in a most standardizable way, is the study of urine transcriptomics, which means that the urine mRNA transcripts are analyzed in different studies, and different panels were constructed able to identify rejection. So different studies were performed. These are some of them, where three genes signature like this one, or a 6 gene signature as this one, were defined, is able to distinguish, as you can see here, the T-cell mediated rejection from non-T-cell mediated rejection, or acute rejection versus non-rejection, or in other settings, distinguish acute rejection versus no rejection. In this study from Crick in 2013, were able to include also children, and their panel was able to distinguish acute rejection from non-rejection with quite a good specificity, but as you can see here, positive predictive value are not very high. So the urine transcriptomic is a good tool, but still there's a lot of work to be done to standardize and to have to obtain more precise panels. Another approach has been studied the metabolites and the perturbation of kidney tissue metabolism assessed in urines with an unbiased omic mass spectrometry-based method, simultaneously measuring multiple metabolites. Metabolites can be strange and weird molecules, maybe we don't even remember they exist, since they were able to demonstrate that some molecules like sarcosin, kynurenine, methionine were able in a particular asset to distinguish T-cell mediated rejection from non-T-cell mediated rejection, including also children in 2 studies, and in another studies, rejection versus non-rejection. And basically what they were able to evaluate and to observe is that proline or kynurenine or sarcosin or other metabolites, which we usually don't consider in our clinical practice, and we don't even probably remember what actually they are doing, were able, in taking them together, to distinguish, as you can see here, non-rejection from rejection on T-cell mediated. This work has been mainly done on T-cell mediated rejection, as you can see here. So these metabolites are actually molecules that are perturbed in rejection, but that we don't even know what they actually are doing. But certainly when they increase or they decrease, can be an expression of rejection quite confidently. Another approach considers instead proteomics, means a whole proteome, meaning that an omic approach is taken, considering the urine samples, fractionation through SDS or capillary electrophoresis, then more precise liquid chromatography, identification with the help of bioinformatics. And this allowed to define, for instance, in the hands of Nele Kantelmeier in Europe in children, a 79 peptide proteome, so 79 peptides which are able to distinguish antibody-mediated rejection versus no rejection with a very high sensitivity and specificity, and also very good positive and negative predictive value, and a very high IUC. While in other hands, results were still very high, but probably validation cohorts are still required. So maybe we are on the right way, but still other validation cohorts are required, and lots of work has been done, especially for children. Another non-invasive biomarker which has been recently added in our instruments is donor-derived cell-free DNA. Donors-derived cell-free circulating DNA in plasma It's been described as being as a biomarker of graft damage, different organs, and the cell-free DNA defines substantially fragments of DNA, small fragments, 100 to 100 base long, released from apoptosis. So what we can retrieve from the blood is basically DNA from the donor, DNA from the recipient, and the first thing is trying to discriminate which is the donor and which is the recipient. And we don't have the time to go through the technical issues, but this the donor-derived liquid free DNA, what we learned is this is an expression of the apoptotic cell. So it's a quantitative, basically, concept. The more donor-derived cell-free DNA we retrieve, the more we can imagine that a damage in the graft is occurring. This has been demonstrated first in the liver, in the lung, and also in kidneys and heart. And the amount of cell-free DNA that we can retrieve, which is not actually that easy to detect, since there are unsolved problems on how to technically detect the cell-free DNA, and how to quantify and how to define the unactional threshold. But the amount of cell-free DNA is an expression of the total transplant mass. So we have developed quite a good experience in liver and in lung, and some quite good data on heart, but still with the kidney, we don't have reached how can I say, a reliable threshold we can consider. The possible solutions now is to go toward a more rapid and less costly system. So we are now using the droplet digital PCR, which is a valid alternative to NGS, providing a quantitative approach with contained cost. This is being done and it's been extended recently also to children for heart and liver transplant, but we still haven't started work on the kidney, but we're confident that maybe we could extend it with satisfaction. On the blood, we can also try to define the transcripts, as we saw on urines, transcriptomics. So unbiased selection of genes can be done also in blood. Some studies and some systems have been also standardized commercially, as the KeySort, the TrueGraph, and other studies have produced a panel of genes that are strictly connected with acute rejection, antibody mediated or not, and other panels are able to discriminate acute rejection versus no rejection. As you can see, every study basically considered different biomarkers, and the biomarker is a sum of differently expressed genes that altogether perform in a quite acceptable way and are able to distinguish rejection from no rejection or antibody mediated versus cellular rejection. This is to try to explain you how complex it is and how every study and every setting basically is quite independent from the others, and then requires a cross-validation. And only a few of them have received these validations, and so are being used quite confidently without starting from the initial phase in each series. Proteomics also has been done in blood, and this the identification of these unbiased peptides present also at extremely low concentration. Blood is quite difficult to study because the confounding prevalence of many proteins deriving from normal tissues is much more difficult than urine. And the protein signature, some protein signatures have been defined. Cybric in 2013 was probably the most successful. With some limitation that this is only a cohort study, and still not so validated by other independent studies. They were able to find in 17 protein signatures some proteins which demonstrated a lower expression, like adherine, AGF, or erythropoietin receptor, MCP1, while others were upregulated and expressed in a higher way, in a higher percentage, in a higher representative in rejection. And these were then discriminated with proteomic techniques, capillary electrophoresis or mass spectrometry or protein arrays. Extracellular vesicles that we saw in urines are also being tried in blood. There are in this field only very few non-cross-validated studies due to the even more complex technical issue, because most of the extracellular vesicles being retrieved come from lymphoid cells, and it's difficult to discriminate was it actually coming from the graft. Two studies I mentioned here, none performed in children, were able even to identify some proteins or some RNA which were expressing rejection. You can see here antibody-mediated rejection versus no rejection, or antibody versus T-cell mediated rejection, quite confident. And this study has no metrics and was only descriptive. This recent study considered either blood and urine and was able to have a good performance of this combined test, able to predict the outcome of a kidney transplant. So on the long-term outcome, not that much to discriminate between the different type of rejections. So to come to an end, new biomarkers, as we have seen, are quite complex world, required long journeys, large collaboratory studies to be demonstrated, to get a shared approval and independent evaluation to become valuable diagnostic and reliable monitoring tools. And this is particularly in children. It takes quite a long time, but new perspectives are certainly behind the door. And if we want to call to action, probably one of the nearest is probably donor-derived cell-free DNA. We've done this in heart and lung transplant, as I told you. And the conclusion is that in lung and heart transplant, donor-derived cell-free DNA is a powerful tool to monitor acute rejection. The test is non-invasive, is rapid, is cost-effective, and can be performed on demand. So the future perspective that maybe we can investigate the role of donor-derived cell-free DNA as a marker of graft damage in pediatric recipients in a multi-center trial, maybe mainly kidney-oriented. And so with this possibility to collaborate on this, maybe within the TransplantChild network, I thank you for the attention, and I'm here to take your questions, if any. Thank you.